So ibrutinib was the first BTK inhibitor approved, and honestly, it was a paradigm-shifting drug. It works so incredibly efficacious in CLL and mantle cell and other hematological malignancies. Unfortunately, it's a little bit of a dirty drug. It has a lot of off-target toxicities, and some of those manifest with things like high blood pressure, atrial fibrillation, bleeding complications, and so tolerance becomes an issue with drugs like ibrutinib, and we've actually learned that people can have cardiac events while they're on ibrutinib for a long period of time. So came along the second generation BTK inhibitors that are sort of have less off-target toxicities, are a little bit more precise. And so there's lots of different ways to sort of manage, ibrutinib toxicity. For some people, you can manage the complication. If the hypertension is mild, you can actually use antihypertensives and manage it. For people where truly the cardiac toxicity becomes intolerant, I think one thing you could try is a second generation BTK inhibitor, whether that be zanubrutinib or acalabrutinib. It's sort of dependent on the approval within each disease, but that's definitely a consideration. And as I talked about earlier today, if drugs like pirtobrutinib get approved, we've actually, there's now some data emerging in the abstract that I'm presenting that shows that pirtobrutinib can be offered in patients who had to stop other BTK inhibitors because of toxicity.